Next to me is Dr. Rhonda Watkins, on top of being a co-chair of this conference. She is a pediatric primary care sports medicine physician here at UCSF. She completed her Master's of Public Health at UCLA, pediatrics residency at the University of California, San Francisco, Fresno, followed by a sports medicine fellowship at Boston's Children's Hospital. Dr. Watkins is also a former track and field Olympian who competed in 2008 Summer Olympics in Beijing, and a former National Collegiate Athletic Association champion. She draws on her personal experiences with athletic training and injuries to shape the way she treats.
All right. Thank you. Good morning, everyone. Thanks, Tom, for that introduction. I'm excited today to share with you on the topic of common overuse running injuries in young athletes. Okay, I have no relevant disclosures. It is my goal that by the end of my presentation today, you'll be able to identify risk factors for overuse injuries in runners. You'll be able to discuss some of the common overuse injuries that we see in this population, as well as discuss indications for imaging and referral. So kids are running. They're outside, they're inside, they're on the turf. They're running alone, running in groups with peers of same ages or different ages. And I look at this and I'm like, what a sight. Okay, it takes me back to my origins in track. I started running competitively around age 8. And track is really, and running is really why I'm here today. It's what brought me into sports medicine and is giving me the experience to treat patients based on things that I've lived and experienced. But for some of you, you might look at this and you think, well, injury risks, are they too young? Is it safe? So it's my goal with this presentation to share with you what the evidence really says in regards to some of the injury risks for these running athletes at this age. So as I mentioned, running is really popular. Worldwide, about 40% of pre-adolescents and adolescents do running as their sport of choice. In the US, it's the second most common physical activity for both boys and girls, ages 12 to 15. And in the 2018 to 2019 high school year, almost 500,000 kids did cross-country, and just over 1.2 million participated in track and field. So these kids you see all the time. It's really common. And that's great, right? Because it's accessible, it's cheap, you don't really need a lot of equipment to do it, and it promotes good bone health, good cardiovascular health, cognitive development, as well as development of athleticism. But the injuries, right? So we know that running-related injuries have been increasing over the past few years. This study looked at running-related injuries coming to the emergency room between 1994 and 2007, and they found an increase by 34%. Another one looked at these injuries that occur in PE. So they looked at PE injuries in the same time frame, and what they found was that 70% of all PE-related running injuries, or not running injuries, but injuries, occur in 6 activities. And running, of course, was one of them. And when you looked at what percentage it accounted for, it disproportionately accounted for more injuries. So about 25% of all those injuries that we see in PE was from running. But there's good news. We can breathe a sigh of relief. Most of the running-related injuries are minor, okay? So they're strains, sprains, things that people will overcome and are able to get back to sport easily with. The more serious ones, which we'll talk a bit about today, like stress fractures, are far less common. So let's get into the risk factors. So when we think about overuse injury risk factors, we can think of them as intrinsic factors, so things that we can't really modify that much, like age, sex, and then there are also extrinsic factors like training, foot strike pattern. So I'm gonna go through some of these, only some, in the interest of time, and try to share with you what the evidence actually states based on these risk factors for youth runners in particular. So when we think about sex, the evidence strongly suggests that female sex places you at higher risk for running-related injuries and greater time loss from sport than boys. So in 2021, the first ever youth running consensus statement was published in the British Journal of Sports Medicine, and they looked at a lot of different studies and sort of summarize what your risk, where the risk lies for these youth runners. So of the 14 studies they looked at that studied sex, 8 of them found that the girls, the cross-country girls, were at much higher rates or higher risk for injuries compared to boys. When we think about age, there's 2 things I want you to remember. So when kids get older, they grow, right? So their bones get longer, but the muscles don't necessarily stretch at that same rate. So that places extra tension or tensile forces at the muscle tendon bone unit junction, which places them at risk for things like apophyseal injuries. At the same time that those bones are lengthening, the bone mineralization is not necessarily occurring at the same rate. It's slower than the rate of growth. So what happens then is there's this transient period where the bone mineral density is lower while they're growing. So particularly at the peak height velocity time frame, which is about 12 for girls and 14 for boys. So in that period of transient decreased bone mineral density, it places them at much, much higher risk for things like bone stress injuries. So when you look at what the data says, however, on age as it pertains to youth runners, we don't have a lot of data to really support this. There's no consistent data that looks at age as a risk factor for youth runners. So one prospective study of high school cross-country runners ages 13 to 18 looked at age and injury risk, and they really found no difference between the average age of those that were injured and not injured. So what about height and weight? So the evidence does not support height and weight as a risk factor for injury in adolescent runners. So one study looked at 230 cross-country runners, and they found no difference in the rate of lower extremity stress fractures in relationship to height and weight for both males and females across a 3-year period. Another study looked at 421 cross-country runners in similar age groups, so 14 to 18, and they looked at the impact of height and weight on in-season injury risk, and they also found that height and weight did not significantly differ between the injured and the non-injured athletes. And that's for both boys and girls. BMI, however, we think there is evidence, strong evidence to support that a low normal BMI is a risk factor for stress fractures in the adolescent female population. Higher BMIs is a risk factor as well. So the extremes, and higher BMI is a risk factor for stress, Shin splints, or medial tibial stress syndrome in cross-country runners. And we'll talk a little bit more about that. So this is one of the studies that brought forth this consensus. They looked at 748 high school competitive runners, ages 13 to 18, and they found specifically this 19 BMI range was cut off. So girls that had a BMI of 19 had a nearly 3 times greater risk for bone stress injuries compared to those with higher BMI or BMI over 19. So remember 19 in your assessment of risks where BMI is concerned. Okay, so what about previous injury? So we know in sport that previous injury is a risk factor for future injury, and the evidence strongly supports that being true as well for adolescent runners where lower extremity injuries is concerned. So a lot of cohort studies have looked at this, and they found increased risk for lower extremity injuries for runners with previous lower extremity injuries versus those without. So a word on training. So there's limited evidence to support some of the training things or training risk factors. But it seems that if you train for less than 8 weeks during the summer, this is a risk factor for in-season injury. So I remember as a young athlete, I was always injured, one thing after the next. And a lot of coaches would tell me, you need to train harder and longer in the off season to avoid injury next season. And that there's some evidence in the literature to support that. So they weren't just crazy. So other things that people talk about is terrain. So we think running predominantly on hills or infrequent alternating of short and long distances, that is with your training mileage in the summer, is a risk factor for in-season injury. So you need to be alternating between long and short distances and mix it up, not just hill work. And this is especially true for adolescent female girls. Also, a low step rate, we think, is a risk factor for shin injuries, and we'll talk a little bit more about that coming up. So, foot strike. So, there's been a lot of work or research on the concerns regarding the impact the foot takes in the running gait in particular. So this graph here describes the vertical reaction force that the body absorbs when the foot hits or strikes the floor in running over time. So it compares that ground reaction force between forefoot strikers and heel strikers. For heel strikers, you'll notice they have this big aggressive loading or peak once that the foot hits with a heel strike. And that is associated with increased forces, abnormal forces up through the joints, the ankle, the knee, and the hip by extension, which can place you at risk for increased injury. The thought is you want to eliminate this first peak and have a more smooth distribution of the vertical ground forces, which can be achieved with a more midfoot or forefoot strike pattern. So there is not a lot of data in regards to how foot strike increases the risk for youth runners. A lot of this is out of adult studies, but for the studies that do exist for the youth runners, we think a forefoot strike pattern may be more beneficial for decreasing injury risk, okay? Certainly more injuries are associated with a heel strike pattern. And the reason for this is we think that there is improved strength and stiffness of the Achilles tendon with a forefoot strike pattern. You tend to load the anterior shin less when you run with a forefoot or midfoot strike pattern compared to a heel strike pattern. And there's reduced contact with the ground, so less stress on the patellofemoral or the knee joint. And this typically increases the step rate. Now, the next couple of slides are really going to be based on expert opinion. So you can't talk about injury risks in youth runners without talking about running mechanics. But there's not a lot of data on this for the youth running population in particular. But it might have been some things that you've heard from coaches if you're an athlete yourself or you have kids that are athletes. And it isn't always information that you solicited, but they talk a lot about overstriding. So have you guys heard of overstriding and the risks it poses for running? So the concept of overstriding, and it's pictured here in this with the X out one, is that the foot lands before the knee. And that really places increased stress on the knee. And it also gives you a stiffer foot, so it actually slows you down. So the thought is that if you can run with the foot more underneath the knee here, you have a more stable stance and less aggressive forces through the lower extremity with the running. The other thing we talk a lot about is hip alignment with the running mechanics. So this is something we look at with gait retraining, and it's no different for a youth athlete. So when you run and the hip falls in, like pictured here, what you can see is there's a dynamic collapse of the knee or a valgus collapse. Dr. Pandya talked about this earlier, and that places you at increased risk for injury as well. So the thought is trying to stabilize the hip alignment as a way to reduce injury. So we know that poor bone health, as reflected by low bone mineral density, increases your risk for injuries in youth runners, particularly for females, menstrual dysfunction, low BMI, prior bone stress injury or fracture, and longer participation in endurance running can increase their risk for low bone mineral density. And we don't want to forget about the males. So they often are a forgotten population, but they also can suffer from low bone mineral density and be at increased risk for running-related overuse injuries, particularly if they have low BMI, prior bone stress injury history, they have low dairy intake, they run 30 miles or more per week, or they have a belief that being thin leads to faster performance. And that gets into this whole concept of relative energy deficiency in sport, which we'll hear a little bit more about later today. So that brings us to some of the injuries that we see in these running athletes. So bone stress injuries are one of the injuries that you'll be familiar with, and we commonly see them in running athletes. We'll talk about some of them today, but I want you to understand that they sit on a continuum, the beginning of which is really something like shin splints. And as it progresses, they continue to run. It could progress to more serious stress reactions and eventually a stress fracture. So I think about it like a paper clip. If you keep bending it, it weakens in the middle. So you're bending, that's the impact of running. And eventually it weakens so much that it snaps. That's when you have your stress fracture. So I want you guys to meet Sally. She's a 14-year-old female who recently joined the track team. She reports she has bilateral shin pain for 6 months. And when you examine her, she's tender over the distal third of the tibia on both sides, but she has no swelling, normal pulses, and she also has pain with a hop test. Her x-rays are negative. So what do you guys think would be the most likely diagnosis for Sally? Is it shin splints? Takers for shin splints. Okay, and then what about stress fractures? Anybody concerned that she might have a stress fracture? Maybe? Okay, so she has shin splints. And so shin splints or medial tibial stress syndrome is really an early stress injury on the continuum of tibial stress fractures. It's caused from overload of the tibial bone and usually is associated with a periostitis. So a lot of times where they have pain is where that bone attaches to the muscle. And I'll show you that in the next picture. And it's common in runners, and up to 25% of runners will see it. So they will present with exercise-induced pain, usually along the distal 2/3 of the medial tibial border. So right here, I talked about where the bone attaches to the muscle. And the pain is usually provoked with activity. It could be during or after. So don't let them say, okay, it only hurts after, so I think I'm fine. Pain that's after activities is pain worth taking note of as well. It usually reduces with relative rest, but they don't have cramping, they don't have burning pain in the posterior compartment, so in the calf here, and they don't have any numbness and tingling in the foot. If they do have those things, you should be thinking more about compartment syndrome. So when you examine them, it's usually over at least a 5 centimeter range. It's not pinpoint pain, and they usually will have no swelling or erythema or normal pulses. So the question on when to image. So this can be a clinical diagnosis. You're really imaging if you're uncertain or you're concerned for a more serious stress injury. So some of you were like, yes, maybe she could have a stress injury or stress fracture. It's important to know, though, that x-rays are usually negative in shin splints, and they can even be negative in early stress fractures. So usually, if you're concerned, you're ending up having to obtain an MRI. It's usually the modality of choice. And for shin splints, you'd see something like periosteal edema, bone marrow edema. So it's managed really with rest and activity modification with less repetitive load-bearing exercises. You can use some air cast stirrups to help with pain if it's really painful, but it's not a requirement. If you are concerned that they may have low bone mineral density, you can check vitamin D labs and optimize that. That will help with recovery as well. And then you talked about some of the gait associated risk factors. You want to look at that and retrain that so it doesn't continue to be a problem. There's no one modality that is superior when it comes to treating shin splints, but a lot of the more recent articles have been on shockwave or extracorporeal shockwave therapy as a treatment modality for shin splints. And this is a non-invasive treatment that uses a shock at the site to promote healing. So a few years later, Sally returns now. She's 16 and she's the star of her cross-country team, but she's lost a lot of weight recently. And her right tibia continues to hurt. It had continued even after she recovered from her shin splints, but now she's like, it hurts a lot, okay? So you examine her, and she has tenderness on the anterior tibia and a positive hop test again. So what do you think would be the most likely diagnosis this time? Stress fracture, perfect. So what are stress fractures? So these are common overuse injuries, and they really occur from overload, and it's not the type of load you think that you need to break a bone. It's from submaximal forces that occur over time. They can be classified based on risk. So low-risk stress fractures are simple fractures that heal well and they're able to get back to sport. The high-risk ones are ones that are at risk for non-union or increased displacement, and sometimes even need surgery to allow these kids to get back to sport. They're also associated with a long break from their activity. So I won't go through these, but you have these as a frame. So it is common in runners. When we think about all sports, stress fractures are most commonly seen in runners. High-risk stress fractures in particular are more common in runners than others. So these are like your femoral neck stress fractures, your navicular bone stress fractures. In any runner that comes in with groin pain and you're not able to get a diagnosis, a stress fracture of the femoral neck should be high on your differential. So bone stress fracture, the presentation of it depends obviously on where the fracture is, but usually the pain will be focal on the places that you can palpate, and it's insidious onset, so it kind of developed over time, and it really progresses from pain with activity to pain just at rest, and that's what you should be looking for in sort of your history. On exam, like I said, you'll have point tenderness, on the bones that you can palpate. There are some special tests that you can do. So I mentioned the hop test, which is just having them hop on the affected leg 4 to 7 times, try to have them go as high as they can go. And usually for lower extremity fractures, it will be painful to do that, or they may not even be able to do that. The fulcrum test is pictured here. And what it is you're using your hand as a lever to put force on the femur, and this can be positive in femoral shaft fractures. So when should you image? A lot of times you're imaging all the time when you're concerned for a stress fracture, particularly if they have a lot of the risk factors that I talked about here. And it should include an MRI, but we usually will start with an X-ray. So remember, you're not going to see anything on X-ray early on. For sometimes 2 to 4 weeks later, you're still not seeing anything. That does not rule it out. So if you're concerned about that, you should be referring. If you confirm the diagnosis, you should refer. Particularly if you have a femoral neck fracture and it is a tension side. So a lot of the reason why some of these stress fractures are high risk is because one, they may not heal well, so they're at high risk for non-union, but also because of location, where they are, some of the muscle attachments put that site at tension, so it's almost as if it's constantly being detracted or distracted. So that increases your risk for prolonged healing or non-union. So we know this to be true of the superior side of the femoral neck stress fractures. So if you see this, you should be referring. If there is a compression side and that displaces over time, you should also be referring, because this is associated with increased risk for AVN of the femoral head. So management is really based on type and severity. So there is a classification system that can grade stress fractures based on severity. It's usually based on MRI, which is why you're usually getting MRI to diagnose it. And then the time frame off from impact, which is the treatment for stress fractures, varies by grade and location. And after whatever time frame of rest, always, they should undergo a gradual reintroduction to activity and impact. Because what we know about stress injuries is if you go back after that prolonged rest too quickly, you put yourself at increased risk for a repeat stress fracture again. And then usually they are doing physical therapy as well to work on any strength deficits, flexibility deficits, and gait retraining. And so how do we prevent some of these things? So you want to limit the total mileage. So 40 miles per week, no more than that. We talked earlier about 30 miles per week being a risk factor for male adolescent runners. So you want to keep the range in that 30 or less. You want to limit running to no more than 4 or 5 days a week. They should have one rest day, and they should be doing cross training with something like biking, swimming, yoga, whatever they choose as well. If they do marathons, they should limit how many they do to no more than 2 or 3 per year. So now I want you to meet Paula. She's 12 and she has anterior knee pain, and it's been going on for 2 years. She doesn't have any injury history, but it started after she started doing YouTube HIIT workouts during the pandemic, okay? So she was not alone. A lot of us was doing this. She doesn't have any swelling. You examine her and she has no tenderness. So you're like, what's going on here? The only thing you notice is that her quads are tight and she has flat feet. So thoughts on what the diagnosis for Paula might be. So does she have a meniscus tear? Anybody think her meniscus can be torn? A lot of squats and lunges with these HIIT workouts at home. Does she have patellofemoral pain syndrome? Good. And any takers for painful plica syndrome? Or OCD of the knee? No takers for OCD? Okay, so she does have patellofemoral pain syndrome, which is, it's named for runners, so also called runner's knee, and it's really friction of the patella as it moves in its groove in the femur. It's characterized by anterior knee pain of insidious onset, so they don't have any injury history usually, and it's exacerbated by things that load the patellofemoral joint. So a lot of squats, lunges, step-ups, stairs, are things that you might hear them report in their history. Important things that I didn't really talk about earlier that can increase your risk for something like patellofemoral pain are lower extremity malalignment. So we learned a lot about this yesterday. One that we didn't hear so much about was the Q angle. You heard a little about it with Dr. Pandya earlier. So that's the angle between the quad tendon and the patella tendon. If that's increased, that puts you at increased risk for instability of the patella and patellofemoral associated knee pain. Other things that I didn't really address are foot hyperpronation. So when the feet fall in, either statically or dynamically, that can increase how much load goes through the patellofemoral joint and cause knee pain. So this can be unilateral or bilateral. A lot of times people will say it feels like burning or aching pain. So if you hear these things, you should think of this. Worse with stairs, running, squatting. And usually it starts with just pain with activity, then it progresses to ADLs, which is really the pattern of all these overuse injuries. Your exam can be normal, but one thing you might look for is this dynamic valgus. So you have them do a squat, either double or single leg squat, and you can see or look for the knee falling in. We talked about that earlier today as well. So when to image? Really, you should be imaging if you are concerned that it could be something else, right? So one thing that it could be is an OCD. So for the people that acknowledged that OCD was a possible diagnosis, that was very prudent. OCD is a great mimic of patellofemoral pain because a lot of times they'll just have anterior knee pain, no swelling, it hurts, and it's going on for a long time, no injury. So you want to think about that as well. For me, I always get 4 views of the knee, which includes the notch view, which is really the view where you'd be able to see osteochondral defect in the femoral condyle. If they have other things that make you concerned for other pathologies, so locking or catching, some mechanical symptoms, you typically don't see this with patellofemoral knee pain. If they have a big effusion, so a lot of them might have swelling, like puffiness at the front of the knee, but not a huge big knee, you should be imaging. If they have limitations in range of motion, you should be imaging as well. I think it's wise. So this is something you can treat well. You see it all the time in the primary care setting. But if they have alignment concerns as well, particularly if they're older, you should refer because you want to know how that's at play for increasing their injury risk as well. And of course, for anyone that you've sent to PT and they continue to have pain, you want to refer as well. So the treatment for this is relative rest. You can use NSAIDs, et cetera. PT, particularly to strengthen VMO core and hip abductors. You can use a patella stabilizing knee brace, but it's not necessary. If they do have flat feet, an arch support might be helpful because you can see here it helps with correcting pronation of the foot, and they rarely ever need surgery for this. How do you prevent it? So a lot of training programs aimed at hip and core strength. For me, this was my first introduction to knee injury or injury prevention as a young athlete. Everybody told me to do leg extensions and leg curls because I also suffered from patellofemoral pain. And then I don't want us to ever forget the importance of maintaining healthy body weight. So we see a lot of overweight athletes. Don't overlook that as a cause for their knee pain because that does overload the knee joint as well. And to wrap up quickly, I'm already over time, but we'll talk about IT band syndrome, which is a common cause of lateral knee pain in young runners. So it's second only to patellofemoral pain. It's caused, we think, from inflammation or compression of the tissues underneath the IT band when the IT band gets too tight. And so the IT band is a long, long band, starts up on the hip and then comes down and inserts at the proximal tibia at Gertie's tubercle. So people will present with sharp or burning pain in the lateral knee, but it can really be anywhere along the track. And they typically will report symptoms with downhill running or when the knee gets into about that 30-degree of flexion range. It often will occur at a reproducible time in their running or distance of running. So on exam, they will have tenderness. Like I said, it can be anywhere on that tract, but it is most commonly in this area at the lateral femoral condyle. There are 2 special tests that you can do. If you come to the exam workshop, we can go through these. But Ober test is pictured here, where you get them into the lateral decubitus position, and you try to extend the hip and then let go. It should adduct. If it stays abducted, it suggests that the IT band is too tight. A Noble test is putting your hand here on that lateral femoral condyle area of tenderness and then trying to reproduce that 30-degree of knee flexion. Pain at that point in that range is sensitive for IT band problems. So it's managed with activity modification. They don't have to stop, but they should probably stop downhill running and all the things that they know are aggravating their pain. PT in particular to address hip abduction weakness, any IT band, psoas, or calf inflexibility. And then here's this shockwave again. This is emerging work, but it's really based on just case studies at this point for managing IT band syndrome. This foam roller here, I often will encourage all my athletes to get. In the primary care setting, you can do that as well. Sometimes that's all people need is foam rolling after and before running. And so when do you image? So usually you don't need to image for this. If you want something to confirm, an ultrasound is probably the best thing. And you might see some thickening of the IT band with an ultrasound. And you rarely ever need MRI. X-rays only if you're concerned about other pathologies. And when should you refer? If you've tried all these things we talked about, they've been doing it for 6 months, and they still have pain. And so how do we prevent this? So increasing pace. So we talked about pace and foot strike and stride or step rate, and how that lower step rate in particular increases your risk for injury. So when you increase your pace, you increase your step rate, and that in particular for IT band takes you out of that 30-degree of knee flexion range. Other things particularly important, I think, is maintaining glute medius strength. So a lot of these lateral leg lifts, that's something they can start to do at home before you get them to PT, can be helpful. So to summarize, female sex, low normal BMI, higher BMI, as well as previous injury are well supported in the literature as risk factors for young runners. Common overuse injuries that you see are IT band syndrome, patellofemoral pain, as well as shin splints. You should have a high index of suspicion for stress fractures, and we know some of the risk factors that should pique your interest for that suspicion. If you suspect it, they usually need advanced imaging, so you should be referring if that's hard to get. And with that, I want to thank you. This is a picture of me at World Juniors doing long jump.